Minraj sir, over to you, sir.
Thank you, Anil. Good evening, everyone. On behalf of Indian Psychiatric Society, Telangana State Branch, Indian Association of Private Psychiatry, Telangana State, Indian Medical Association, Telangana State, and Indian Medical Association, Hyderabad City Branch, I welcome you all to this wonderful evening. Today is 10th October. 10th October is celebrated as World Mental Health Day. Today it is very important day and concluding day of our series of webinar for the whole week. Today we have a very eminent speaker, Dr. M.S. Reddy sir, who is very senior. He was president Indian Association of Private Psychiatry, and he has held various positions nationally as well as internationally. We also have eminent panelists like Dr. Anurag Srivastava sir and Dr. Harish Reddy. Today we have quite eminent people in our panelists as well as in our attendees list. So today, apart from the seminar and panelist discussion, we'll have take-home messages and messages, special messages from eminent people of Indian Psychiatric Society and Indian Medical Associations after the session. So please don't log out just after the session. Please wait till the end. Thank you. And I'll hand over the proceedings to our president, Dr. Jagannath sir.
Good evening, all the viewers. On the behalf of IPS Telangana State Branch, I welcome all of you for this awareness program. I especially welcome all the IMA City Branch members who are co-hosts for this program. I take this opportunity to specially welcome Dr. P. Raghuram Reddy, our teacher and senior most psychiatrist in the state. Today is the last day of the World Mental Health Awareness Week, and today it is the World Mental Health Day. Yesterday we had a talk by Dr. Minhas on somatoform disorders, and today it is the most important topic among all the psychiatry disorders, that is depression, by an eminent speaker, Dr. M.S. Reddy. Dr. M.S. Reddy is an internationally renowned speaker, and he is an authority in treating mood disorders. Today's program is chaired by Dr. Uma Shankar. Dr. Uma Shankar has done his MBBS from Kakatiya Medical College and a MD Psychiatry from Usmania Medical College. He is a professor and head of the Department of Psychiatry, Gandhi Medical College, and currently he is the superintendent of Institute of Mental Health, Hyderabad. He is the CEO and member secretary of the State Mental Health Authority. He was the past president of Hyderabad Psychiatry Society and past president of Indian Psychiatry Society, Telangana State Branch. Under his leadership, Institute of Mental Health was recognized as one of the best psychiatry hospitals in the country. It was awarded the Center of Excellence by the central government. Everyone agrees with me that the only difference between government and private hospitals is with respect to the comforts to the patients and the cleanliness. I'm happy to inform you that under the guidance of Dr. Uma Shankar, the Institute of Mental Health Erragada was awarded ISO certificate for hygiene maintenance. You know very well that during the COVID pandemic, the most affected hospitals are psychiatry hospitals, and some centers were actually closed. In these difficult situations, Dr. Uma Shankar has effectively controlled the infection in the hospital and has done a commendable job. Now I request Dr. George Reddy, the president of Indian Association of Private Psychiatrists, Telangana State Branch, to say few words. Dr. George, please. Dr. George Reddy?
Yes, sir.
Yeah.
Good evening. Thank you, Dr. Jagannath, sir. First, on behalf of IAPP Telangana State Branch and IPS Telangana State Branch, first I would really welcome our IMA City Branch President Dr. R.K. Yadav, sir, and the General Secretary Dr. Krishna Pawan, sir. And it's overwhelming to be with you as the co-host, sir. And I'm sure this topic today, I think it will be useful for all of us. I think today's speaker, Dr. M.S. Reddy, I think we psychiatrists, we all know him, sir, and I'm sure the members from IMA, many know him. He is a senior psychiatrist and an authority on mood disorders. And my personal choice, when I can't make my patients okay with my care of Dr. M.S. Reddy. And here today we have Dr. Umashankar, sir, who will be the chairperson. He needs no introduction. I think he's doing a wonderful job and definitely a role model for me. And we have Dr. Anurag, sir, who is again the head of the department for Medicity. And it will be so nice to hear from him. And we have a young dynamic psychiatrist, Dr. Harish Chandra Reddy, who is really another upcoming member for our associations. Welcome to you all. And I should thank on this occasion to see all the young psychiatrists, they're trying to respond when I send them the messages, reminders. Really, I think I should thank you before the vote of thanks. And I only request all of you, please be live until the program ends. Today, I think we have even increased the program by another half an hour because until yesterday we could see that we were trying to finish the program, though many members were having questions. And thank you, Dr. Jagannath, sir. Thank you, one and all.
Okay. Thank you, George. Now I request the IMA City Branch President, Dr. Rajendra Kumar Yadav, to say a few words. Sir, unmute yourself, sir.
Yes. Good evening, all of you. I would like to thank Dr. Jagannath, President for Indian Society of Psychiatry Society, and Dr. George Reddy, President for Indian Association of Private Psychiatry, Telangana State Chapter. And this is in fact a proud moment for Indian Medical Association Hyderabad City Branch to be associated with Indian Psychiatry Society, Telangana State Chapter, and Indian Association of Private Psychiatry, Telangana State Chapter. Today being the concluding day of week-long program of Mental Awareness Week on Zoom platform, and the topic being the depression, which is followed by the talk on the kindness matters. As a president, I would like to inform the members present here that IMA Hyderabad City Branch is one of the largest and one of the oldest branch in India with 5,500 plus active members. We conduct regular academic activities in the form of orations and continuous medical educations and free health camps at different places. I would like to thank the organizer for giving me this opportunity, and special thanks to Dr. Minas for working on this and making this happen. And I would like to read the slogan for World Mental Health, that is being mental health for all, greater investment, greater access for everyone, everywhere. We shall all work together to bring awareness in the society regarding the wellness of mental health. Thank you all.
Now I request Dr. Krishna Pawan, Honorary Secretary of IMA City Branch, to say a few words. Dr. Krishna Pawan, please. Sir, please unmute yourself.
Okay. I would like to thank Indian Psychiatric Society, TS Branch, and Indian Association of Private Psychiatry, Telangana State Branch, for giving me the opportunity to, I would thank Dr. Jagannath sir and Dr. George Reddy sir and chairperson and panelists And I would like to thank Mr. Minas sir for giving me the opportunity. Thank you.
Thank you, Dr. Krishna Pavan. Now, one of the senior most members of IMA City branch and past president is here, Dr. Dilip Bhanushali. Sir, I would like, I request you to say a few words on this occasion, sir. Dr. Dilip Bhanushali. Minhas? Okay. If you are not able to reach Dr. Bhanushali, I request Dr. Uma Shankar.
Hello.
Dr. Uma Shankar.
Sir, Dr. Dilip Bhanushali is here.
Yeah, okay. Sir, Dr. Dilip Bhanushali, sir, say a few words about this program, sir. Thank you.
Good evening. Good evening. It's a great honor to be here on this webinar being conducted by the Psychiatric Society of Hyderabad and Telangana. We are proud that Hyderabad City branch also has joined this, and it's a wonderful program. I believe it's been going for last one week. Dr. Meena has been doing wonderful job on this. I think in this difficult period of COVID-19, the trauma which the physicians and the doctors are going through is an apt subject to be dealt in details, and what the Psychiatric Society have done a wonderful job this. I congratulate every one of you. Thank you very much for asking me to speak something. Thank you.
Okay. Thank you, Dr. Bhanushali. Now I request the chairperson of today's meeting, Dr. Uma Shankar, to take over. Dr. Uma Shankar, please.
Good evening, all of you, sir. Today is an important, very important day for all of us. Being a psychiatrist, the people to help the the need people, we have to help them. So for that, we are since last 1 week, we are giving some sensitization and also awareness program since last 1 week. So today we are ending up that awareness, but it should not stop here. So like this, we have to in the future also, we have to create some of the awareness programs throughout the medical faculty that may be helping the society to enlighten, and also they can help the people in turn. Today's topic is depression. Talk on depression. It is by Dr. M.S. Reddy sir. He is a well-known senior most psychiatrist, and he's the sir did his MD at Christian Medical College, Vellore, Healthcare Management in Indian School of Business. He is a director, Asha Bipolar Clinic, Hyderabad. The past president, Indian Association of Private Psychiatry, past president of Indian Association of Biological Psychiatry, honorary secretary of Society for Bipolar Disorders, India. He is the editor for IJP from 2006 to 2017. He is also a council member of Asian Network of Bipolar Disorders. He is also council member of Asian Association of Neuropsychopharmacology, member of editorial board of World Journal of Biological Psychiatry. He is a member of editorial board of Asian Journal of Psychiatry. I think if you want to say a lot of thing about him, is a very kind person. Whenever, whoever it may be, even juniors also, he will speak to him. He will comfortably, he listen to them. He will try to clarify their doubts. So most of the patients, those who go to him, they also say that sir is very good. He is helping a lot that way. But sometimes because of his busy schedule, some people, they cannot reach them. So that is the reason sometimes they spillovers, they'll come to us. So those people will be saying that he's a very nice gentleman. Today, I think we can, we can share, we can learn from him. I think, thank you, sir, for today's program. as a lecture, everybody is benefited. And other panelists today are, two panelists are there, Dr. Anurag Srivastav and Harish Chandra Reddy. And today is Anurag Srivastav. He is a professor and head Department of Psychiatry, Medcity Medical College. And he is a not only great psychiatrist, he is a psychoanalysis and psychotherapist. He is worked in as assistant professor in Deccan Medical College from 1991 to 1990 to 91, 2001, and again from 2005 to 2006, I think. And after that, he was worked there itself as a associate professor. Then he was shifted to this Medcity Medical Sciences, Medcity Institute of Medical Science, Hyderabad, as a professor HOD in 2011. Till date, he is working there. Under his guidance, so many people, they learn how to do the psychotherapy. He's a very gentleman. I think we can learn a lot of things from him. And he got so many publications. Because of paucity of time, I'm not going to entire this thing. I think it definitely will take his all biodata. Almost it may take another 15 minutes. So I'm skipping all the things. With this, I think we can go to other panelists. Is Dr. Harichandra Reddy. He is a consultant psychiatrist at Sahara Mind Clinic, Kukatpalli. He is a visiting consultant at Apollo Hospital, Kondapur, Indo-US Hospital, and Lotus Children's Hospital. He is a visiting psychiatrist. He has done his master's in psychiatry from Fatima Medical College, Karimnagar, under the guidance of Dr. Professor Kishan. His father is Dr. Bhagya Reddy. He is a first teacher as a psychiatrist. His work under mentor is Dr. Praveen Chintapati. His area of interest includes child and adult psychiatry and substance use disorders, alcohol and other substances, mood disorders, and anxiety disorders. He writes regularly to psychological problems in reading newspapers, and also he attends some of the TVs also. This is a very dynamic person. He involves most of the things. With this, I say that this is a very important day. I think everybody can carry some message from Dr. M.S. Reddy Garu. I think with this introduction, I request our other panelists say a few words, and then we can start with the speaker. Sir, Jagannath sir, please unmute.
Sir, I think we'll go straight to the topic, sir. At the end, we'll allow the panelists to talk. Sir.
Yes.
Okay, then
yes.
fine. Okay, then fine. Sir, thank you, sir. Sir, M.S. Reddy sir, please, please start your presentation, sir. Thank you, sir.
Thank you. Thank you so much, Dr. Umashankar, for your very kind words, especially for giving that adjective, being kind to my name, especially the theme being kindness. Thank you so much. I feel really like an honored and then overwhelmed by your giving me that adjective that I'm a kind person. Coming to this, IPS TSB President Dr. Jagannath and IAPP TSB President Dr. George Reddy, my guru Dr. Raghuram Reddy, Dr. Minash, and all other senior psychiatrists and some other non-psychiatric medical colleagues. And Jagannath told me there are some people who are non-medical, non-medical people are also here. So let me see in my presentation on depression, which is very, very important topic. A group of psychiatrists, non-psychiatric medical colleagues, and with the lay people, to what extent I can try to reduce the jargon and see that whether it is palatable to everyone who is here. So to start with, depression, as everybody told, that is a very, very important topic and also one of the most common psychiatric disorders, as most of us know. So if you look at this, Depression is awful. The beyond words, sounds, and images, these are the words by none other than K. Jamison in her book Unquiet Mind. She herself has gone, she's a psychiatrist and then gone through depression. This is how she describes it. The next sentence, I think even the non-psychiatric medical colleagues and the other non-medical people also should understand that major depressive disorder debases brain capital more than any other medical disorder. There are now, like in so many medical disorders, we all talk about intellectual capital, human capital. Depression literally slows down your intellect, your brain. The debasing brain capital is the maximum with this. There is no race, ethnic, or demographic group, country, culture that is immune from the hazards of MDD. Maybe President of United States may say that I will never be infected with COVID-19, but I don't think anybody on this planet Earth can say that I will never get depression. It's like typhoid, it's like diabetes, it's like any other illnesses. So it can affect any person. Depression is treatable. These are some of the things for most of the psychiatrists who are here. They may look, like a very basic, and that's one. But you have to pardon me because there are other non-psychiatric medical people are also there. So I'm going very basic. Depression is treatable. Treatment is simple, and episode is curable. That is why I always say that mood disorders are good prognosis disorders. And this is the most important statement, sir. Most of you, the IMA from IMA, Dr. Yadav, Dr. like the other people who are here, I want you to note this point, saying that major depressive disorder can be successfully treated in a significant percentage at the primary care level. This is very important, especially now when you know that. I'll be coming to that statistics now, like the next slide. Yeah, this is the thing. It's a most common mental disorder. Its current prevalence is 2.7%. I think today the Economic Times, there is an article saying that now, like almost like 45 million people in India as and today are diagnosed as major depressive disorder, and we are less than 10,000 psychiatrists. I think unless the non-psychiatric medical colleagues chip in, it's not going to be easy to manage this burden of depressive disorders. And this is the thing. Of all the psychiatric illnesses, depressive disorder alone occupies 25% of the space. And all of you know that in any general hospital, in any general practitioners, like an OP, 30% of the cases are depression and anxiety. It's a common disorder, and quite often it can be serious mental disorder. Lot of times, here at this point, I'm going to come back again. Lot of times there is saying that, oh, what is the difference between depressive disorder and sadness? A lot of, like in psychiatrists, like in a diagnose even sadness as a depressive disorder. Sir, here, very clearly, this is National Mental Health Survey, which is finding in 2016, 75% of the people who are diagnosed as major depressive disorder have moderate to severe depression. Mild is only 25%. 75% have moderate to severe depression. And this is the most worrisome. 15% of them have suicidal risk. 15% of patients with major depressive disorder end their lives by committing suicide. And our job as somebody, as a medical practitioner who is treating that, to what extent we can prevent this. That's going to be the most important thing. And this is, again, this is a very common thing. Depression is a cause and also consequence. I'll come to it. Non-communicable. You take diabetes, you take hypertension, you take cardiac disease, you take musculoskeletal disease. Almost all. I don't say depression is the cause. Depression is one of the important causative factors in all this, either development of these disorders or perpetuation or exaggeration of your blood sugars, your hypertension, or mostly it could be because of that. I'm going to slow in and show it in another slide also. So the burden of depressive disorder gets amplified because of this relation. Depression being one of the causes for development of hypertension, cardiac problems, and cardiac problems again leading to depression. I'm going to show the slide. It's almost a WHO survey showed that major depressive disorder, the greater decrement in perceived health than cardiac, musculoskeletal, respiratory, and then endocrine disorders. compared to many of the medical disorders, this carries daily is high. Disability adjusted life years, years lived with disability, years of life lost. All these are very high with depression compared to most of the medical disorders. And at this point of time, this is only just a reminder to my psychiatrist colleague friends, but for all the other doctors, this is one of the saddest thing which happens. More than 50%, almost 40% of major depressive disorder, age of onset is 20 years. This is one way I'll tell you that one of the unfortunate things which happens in psychiatry is that majority of the disorders, you take schizophrenia, you take bipolar, you take depression, you take OCD, almost all the major disorders, quite a lot of them, age of onset below 20 years. Second decade, the boy, man, he is in his adolescent, education, his personality development, his relationships, the whole thing. That is the time depressions affect them. Unless it is treated very effectively, complete cure, it's going to affect him for his life. That is what is saying, which is very, very important. We have to understand when we talk about depression, the age of onset. Other chronic illnesses, your diabetes, hypertension, cardiac, all starts after fourth decade, fifth decade. I don't say that after fourth decade, you know, like in your life does not matter. But imagine somebody at the second decade it starts. And this is what the finding of National Mental Health Survey. This has been done by National Institute of Mental Health, 2016, depressing treatment gap of 86%. Now, I think some of my IMA colleagues, other medical colleagues asked, Dr. Reddy, just one slide before you said depression is treatable, treatment is simple, episode is curable. And very next slide, you're saying that there's a treatment gap of 85%. That means that only 15% of patients with major depressive disorder are being treated effectively, completely. Well, what is this gap? Why is this? That is the sad part of story, sir. One of the reasons being resources, the manpower being extremely very, very low. As I told that, as in today, there are about so much, almost 4.5 crores of people with depression, and the psychiatrists are less than 10,000. Where do we get? Psychologists are much, much less. Social workers, you don't even talk about psychiatric social workers. That is where this gap. How do we fill this gap is also one of the important things. Today, I'm sitting here and talking to other non-psychiatric colleagues and also some of the lay people is that how do we all together try to fill this gap? At least by another quarter century, can I bring this down to 50%? That's going to be a great achievement. We have to do that. How do we do that? It's going to be the thing. This is what I was talking about. Depression can be one of the causative factors for diabetes, hypertension. And this again, chronic diabetes, hypertension, cardiac, again leads to depression. It's a cycle. It's a bidirectional relationship. That is where the burden of depression becomes worse. The same thing, the same point what I told, 75% moderate severe. This is one of the American study, this now 2003 adolescent, almost 85% moderate severe. Why I am stressing this point is because the problem is, I think my first slide I put it, depression, the disorder. One of the major problems for us is that the expression of depression, I feel depressed, I'm sad, which is a normal emotion of every human being, and sometimes it becomes a disorder. Where do you differentiate? For a layman, how do you differentiate this? A lot of times people say that normal sadness being diagnosed as depressive disorder. No, sir. This is the severity. And I'll also come to it why it's not like a routine sadness. It's a normal emotion. All of us go through. That doesn't need treatment. But you cannot mistake it now like a depressive disorder as a normal, simple sadness. That is why important seriousness. 85% of them are the severity is so high. I think this one picture clearly depicts the normal man with the bounce, with the spring, with the full of energy and all that, what happens to him. Literally, sir, literally. I think all of psychiatrists, we know that what happens to somebody with a fairly moderate, severe depression, he's totally flat in psychologically, motor activity, emotionally, cognition, everything becomes flat. This picture is a clear depiction of what happens to somebody with depressive disorder. Now, this is DSM-5. like 1, 2, 3, 4, 5, 6. All of us know that we go by the criteria. Here again, I say that depressive disorder is not diagnosed just because somebody walks in saying that I feel sad, I feel low, I feel. No, sir. 2 weeks is the minimum period, and this is the most important thing. Most of the time in the day, most of the days in the week, it has to be. All of us feel sad, something happens for a few minutes, for a few hours, but it cannot be. It has to be very clearly, they said that. So when you make a diagnosis of major depressive disorder, you're clearly delineating it from sadness. Anhedonia, anyway. Diurnal variation of mood. This is very, very important, especially some of my, now like in medical colleagues, I say that this is, even now we do not know why it happens. People with major depressive disorder, especially one subtype called melancholia. This is a beautiful thing about this. This is not like for the patient suffers. One is this, second is this. Generally, most of us, when we are having a little bit of tension, anxiety, worry and all, we go to bed. We struggle, we don't get sleepy, keep rolling and all things, 10 o'clock, 11 o'clock, 12 o'clock, 1 o'clock. And then later we sleep around 3 o'clock. But in depression, melancholia, what happens is, patient goes to bed, he sleeps off immediately. 9 o'clock, 9:30, sleeps off. But he wakes up at 2, wakes up at 1, wakes up at 3. That is why we call it late insomnia. And from that time onwards, he's miserable. His thought process is nothing but a negative cognitions. And the another part is that a lot of patients tell us, doctor, I don't know. I wake up with a really totally sad mood. But as the day passes, 10 o'clock, 11 o'clock, 12 o'clock, evening 3 o'clock, 4 o'clock, I feel much better, doctor. The next day again goes like that. I wake up with the terrible. The whole thing I remember is that I am completely overwhelmed by negative emotions. So mornings it's like that. By evening it becomes better. And again the same cycle goes on. This still we are not able to explain scientifically why it happens, how it happens. This is one of the pathognomonic features of a clinical depressive disorder which has got a biological etiology. These are all non-specific things. That's why I emphasize these 2 points here. Diurnal variation, late insomnia, and unless it is for 2 weeks duration, we don't diagnose major depressive disorder. Right. We all know that patients do not walk into a clinic saying that, doctor, I'm sad, I'm depressed. Majority of the times it's a physical things like headache, backaches, and then body pains, and the weakness, lethargy. So what they say, 70% of the patients report physical symptoms. When they report physical symptoms, sir, the first contact point is not psychiatrist. It's a general doctor. It's a general physician. Anybody other than a psychiatrist. So this 70% of the people, sir, you're going to see the patient, not we. So they come to you, they present to you with non-specific symptoms, which we give in different names like somatoform disorder or fibromyalgia or whatever it is, but it's underlying depression. Unless you diagnose it correctly, we are going to miss giving him a lot of painkillers and then non-specific medication. So that is where, which is very, very important here. And then I think most of you know, this is one of the scales where, a quick in a busy schedule of your OP, it's PHQ is one of the things which you quickly, one of your assistants can apply that. If the score is more than 10, it indicates presence of major depressive disorder. I think most of my colleagues who are in general practice can take it up and then easy way, quick way to diagnose major depressive disorder. I want once again, this is mainly for the focus of our non-psychiatrists who are here. What are all the age groups? What are all the different presentations that depression can present in? A 64-year-old who is not sleeping and eating for the last 3 weeks, possibly depressed. I'm not saying that these are all definite depressive disorder, possibly depressive disorder. 45-year-old homemaker who cries, possibly, most likely, differential diagnosis of the clinical picture should be major depressive disorder. 39-year-old persisting fear of cancer. Fear of cancer. He doesn't have it. But now, like last 2 months, suddenly he has got the fear. Then now it's more of a COVID. Sometime back it's HIV, something like that. Persistent. It could be obsessive thought. 35-year-old executive is fatigued. All the time he feels a bit dull. Nowadays we call it as chronic fatigue syndrome, fibromyalgia, but it could be depression. Newlywed, always accused by in-laws being lazy. Poor lady, she's depressed. But now, people misunderstand. 20-year-old slashing his wrist. A lot of times we have relationship problems, but somebody who's doing this kind of a deliberate self-harm, he could be depressed. 18-year-old who is a recluse, just don't know. They can't, most of the times, relatives ask, parents ask, what is the problem? They just can't explain. It is like, it's like any other biological disorder. He cannot explain, but he's feeling sad, low. 16-year-old, loss of interest in studies. 10-year-old girl developing school phobia. See the range, starting from 10-year-old up to this, all of this, I think every psychiatrist knows that any of this can be a significant, prominent indicator to tell us that this person must be having depression most commonly, if you rule out other kind of routine investigations and then with other causes. So this is a range and this is the variety of symptoms it can. This is how they look. Need not be all the time the patients. Now, this is also one of the things like that. No, he's looking so cheerful. He's looking so happy. How can you say that he's depressed? No, sir. This is one of the maybe not like a very severe depressions. This is also not like hitting the bottle. Substance abuse, self-medication can be one of the things where people depression can go into. I think we are all medical colleagues. Diagnosis is a must. We all know that diagnosis indicates prognosis, diagnose directs therapeutics. But other than psychiatrists, all of you have the luxury of this. But we, at this point, maybe I'll say that we poor psychiatrists, we don't have this luxury. No laboratory test to confirm or diagnosis. That is where one of the biggest problem. A patient with mania walks into my clinic and says that, like you diagnose with mania, he'll ask me that, where is the doctor? All my reports are normal, everything. So that's where always like in a weak point. At some point of time, we all hope that we'll get some biomarkers and then at some point of time, it will be easier for us to deal with the patients. No laboratory diagnosis. We are lost in that. So clinical presentation, there's a repeatedly again and again history and clinical presentation, current history, past history, family history. These two, I say that very, very important. Maybe this is message for mostly to my medical and the psychiatric colleagues. Lot of times, as I have already told, clinical presentation MDD will not come with the DSM-5 1, 2, 3, 4 criteria. Very non-specific symptoms. That is the time in my clinic, in my routine practice, I find these two are very, very important. For example, somebody walks into my clinic and he gives about a lot of somatic symptoms, some headache, some backache, some weakness, doctor, some once in a while, no sleep. After that, suppose he says, doctor, I had a similar kind of symptoms in 2009 for a few months. Then I became all right, that's it. Then again, 2015, I had doctor for about 3-4 months. Clearly, something like this I had. 1 second, I have no doubt to call it as a recurrent depressive disorder, which 99% I am right. Similar way, somebody comes with a very vague symptoms, but you don't have a laboratory diagnostic. Then I get a history saying that my maternal uncle was an alcoholic. Doctor, my mother committed suicide and she died from suicide. Current picture is not very definite, but the family history of a first degree relative having suicide and then again second degree relative alcohol or somebody else having, it clinches the diagnosis, which most of the times I take it as a phenotype biomarkers. This is mostly to my psychiatric colleagues I'm talking about, because we don't have lab diagnostics. Then if it is a vague presentation, how do we conclude? If I don't make a definite diagnosis, as I told that, my treatment will not be as aggressive. Once you make a definite diagnosis, you go the first line, second line, third line, fourth line. Otherwise, you are always, keep very vague in your treatment. That is where these two becomes a very, very important thing. It doesn't take much time, less than 5 minutes for you to elicit this, which I look at as a very important phenotypic biomarkers. Sir, I want the attention of all our non-psychiatric colleagues here. Most of the times, when a patient walks in with a depression, the first question is, why are you depressed? Poor man, he doesn't know why he's depressed. But we all have a preconceived idea saying that there has to be some stress, there has to be some problem, there has to be either mother-in-law, father-in-law, alcoholic husband, a loss, failure in less business. No, sir. I think this slide is a very, very important slide. The most severe psychotic depression, level of stress is virtually zero. Without any psychological stress, a patient can develop an MDD with psychosis. Unipolar depression is also its mind. Severe depression is all grief and adjustment disorders. I don't try to undermine the psychological factors, but here, because this is very important, because your treatment approach is very, very important here. All the time trying to dig into the stressful factors, sometimes you miss the, like in a larger picture here. That is why the no stress, severe, most severe depression, you have it. Mild stress, you have again the severe type of this. And a severe form, you have only grief reactions where a lot of times with the counseling, they can be managed. This is a very, very important a change in paradigm shift in the last half a century in the approach to the causative factors of depression, which is very important, which has to be conveyed to all our medical colleagues so they understand this as a medical disorder, which is very, very important. Right? Somebody has an episode of depression. Only 50% of them will have a second episode. That means, sir, why I'm telling this to our medical colleagues is that a patient with major depressive disorder, you treat him successfully, you have treated him successfully for the life in 50% of the cases. They may not have the second episode. Second episode, third episode, maybe let the psychiatrist manage that. So the rewards are very high if you treat major depressive disorder in your clinic. And the treatment is simple. This is one point which again, most of the times mood disorders have natural course of recovery. Suppose this is normal, this is depression, is a depression. You give antidepressants or whatever the treatment, he recover. Suppose you don't touch, you don't treat, you don't do anything. Still, a lot of patients recover. But the problem is that this period of morbidity, mortality, and then suicidal risk, they do recover. Why I'm talking about this point is that a lot of times our job is to facilitate this. Instead of allowing the person to have a 6 months or 8 months or 9 months of depression, I cut it short to 3 weeks or 4 weeks. That is what our pharmacotherapy does. That is what our medicine's job is. This is a very important point. At this point, your antidepressants are very effective compared to placebos and all that. But at this point, if you look at it, your aerobic exercises, St. John's wort, equal in effectiveness with imipramine, escitalopram. A lot of times people argue that I have given this patient has recovered, but it takes a long time. Our job is to cut it as short as possible, which is very, very important. Placebo effect can be there here. So now he's right when he says that I have given St. John's wort, the patient has improved. Yes, he has improved after 9 months. But I have given SSRI, fluoxetine, patient has improved, but he has improved in 1 month. That is the difference which we all have to understand. What are the therapeutic goals? Recovery, prevent the suicide, mortality. Let me not talk about preventing future episodes. We all have tricyclics, very good drugs, but the problem is significant and serious side effects. Now it's the SSRIs which rule the domain because they are effective. Any treatment, unless it is applicable, replicable, affordable, accessible, no way it's going to be practiced. It's not going to be possible. CABG, now it comes into all these things, now it is widely used. At one point of time, if somebody has to get a CABG, he has to go to Houston. No, that is it. So ECT is excellent form of treatment, but anyway, let me talk about it. Psychotherapy also, sometimes the replicability of it is not going to be easy. So that is where simpler SSRIs, I'm coming to these 2 drugs. And then right now with this COVID period, teleconsultation is doing a phenomenal service to psychiatry, reducing the stigma and then last mile accessibility. Unbelievable kind of a service telepsychiatry is doing today to the field of psychiatry and patients with psychiatry. Stigma is a big problem. It's cutting down the stigma mostly. Why patients don't talk about? They are embarrassed. One of the most important thing is when somebody says I'm depressed, oh, you can't even manage that, you don't have willpower, he's finished. Avoid sympathy. Hold themselves responsible for their agony. This is what, why are you depressed? We try to put the blame on them, which is a very wrong question we ask. This is obviously lack of awareness. That's why we are trying to do wrong notions about treatment. My God, public are scared of psychotropic medications. I'll tell you, sir, all my IMA colleagues, drug escitalopram and sertraline are such a safe drugs. I can say that maybe they are safer than paracetamol, but the kind of misconceptions people have about is unbelievable. So I just took only sertraline and escitalopram here. This is the dosages. The problem in depression is that it takes about 3 weeks. So when you start the medication here for almost about 3 weeks, generally 2-3 weeks, not much of a change, and then it starts. But these 3 weeks holding the patient is going to be an extremely difficult task. Your education, counseling, holding his hand, and then caregiver, all are very, very important. And this is the goal we need to achieve. Yeah, just 1 or 2 slides. I want to talk about the biomarkers like right anterior insula. If there is a hyperactivity, it's supposed to respond better to escitalopram. If it is hypoactivity, it's supposed to respond better to CBT. This was a study done in 2013 by Helen Mayberg, but not really much replicated. Otherwise, we would have had one very good important biomarker for the therapeutics. This is the most important thing. Depression diagnosis, no problem. I have good drugs today, SSRIs, but the problem is this treatment does not help, patient does not use it. Study, there's a very high attrition rate. So for the patient to take the drug, there are some important things which all of us have to accept. Diagnosis of patient should not think it's a simple sadness. Patient should be able, patient and the family should accept that depressive disorder is there. Biological causation concept they have to accept. Therapeutic benefit. A lot of times, oh, I'm a psychological problem. Why are people giving medications? You need to do psychological problems, presentation with biological etiology. The final common pathway, whatever may be the causation, is serotonergic system dysfunction, and that is where SSRIs work, and they're very safe drugs. Caregiver is very, very important, unlike in other specialties of medicine. Here, especially, my patient with depression is completely, totally overwhelmed by the negative cognitions. All negative, negative about self, negative about future, negative about world. Then how do you expect him to be positive about the treatment? No, it's not going to be. That is where caregiver is, whoever is the caregiver is very, very important. Delayed response is another problem. We all have to have recovery metrics, psychopharmaceutic alliance, which is the most important thing, especially in the first 3 weeks. So at this point of time, I was looking at it, and then I found that this is what I practice. Every patient with major depressive disorder I diagnose, I look at the caregiver and tell that, Amma, you should give the medicines, please, for the next 3-4 weeks, at least till he becomes better. And this is where, after looking at the study, horrible attrition and then lack of compliance, I found that somewhere I was looking into that, the tuberculosis, anti-tuberculosis pharmacotherapy, efficacy was excellent when they did RCTs. But when it came to the field trials, effectiveness has come down from 90% to 50%. So this is the method. Directly observe treatment. It's like anti-TB pharmacotherapy. I feel that it helps improve compliance and adherence, which is going to be the important thing. And some of you may ask, how do you compare depression and tuberculosis, Dr. Reddy? Where is this? This is one infective illness. This is one, like non-communicable depression. You don't even know it's a disorder. Let me like maybe spend a minute in this. The first antidepressant, sir, iproniazid, was an anti-tuberculosis drug. 1950s, the Staten Island of New York, where there's a sanatorium, tuberculosis sanatorium, the new drug which has come as introduced as an anti-tuberculosis drug, which helped in controlling the tuberculosis bacilli, also helped in lifting the moods. Iproniazid, the drug, the anti-tuberculosis, and also an antidepressant, that's where it started. For a long time, we all know that tuberculosis was thought to be because of lack of good nutrition and then good hygienic air and all. It was in the sanatoriums tuberculosis was treated. For a long time, depression was thought to be about loss of loved ones, and then psychological reasons and all those things. That is why it has become. For both depression and then TB, pharmacotherapy developed in 50s. Even for anti-tuberculosis treatment, it came in the 50s. Before that, we did not have any pharmacotherapy for tuberculosis. And both of them have latency in response. And lastly, even after third month, sputum becomes negative. Still, you are asked to continue medication for the next 6 months or 9 months. Even when the HAM-D score becomes less than 7, you are asked to continue medication, the continuation and then maintenance phase. So I found a similarity between antidepressant treatment and then anti-tuberculosis treatment. Phenomenally, directly observed treatment has improved outcomes in tuberculosis all over the world. Even the most developed countries like in Europe and then US practice this. I wish, wishful thinking that directly observed treatment, which is their ASHA worker gives, here I expect the caregiver gives, that reduces the mental health gap and improves recovery rates in MDD. You remember 89% of MS gap I talked about. Maybe this is one of the things, I don't say that thing, it's one of the things which can help. Each recovered patient is a brand ambassador. Absolutely, there's no doubt. How do you reduce stigma? Every recovered patient goes out and says that I had problem, I went to the doctor, I became all right. Talks more like in volumes than me talking about health awareness. Last slide. You talked so much, Dr. Reddy, but as a non-psychiatrist, we don't hear about in patients recovering in psychiatry. No, sir. Mood disorders recover. Each episode recovers. I repeatedly say that. You look at the slide, 2017, major depressive disorder. At the end of 2 years, 60% remained recovered. Total recovery. And then this is that had a recurrent, but again, not a chronic, again, second episode, but again recovered. Forget about 2 years. Let's come to the 6 years follow-up. You treat a patient with major depressive disorder, patient has recovered. At the end of 6 years, sir, 32% of your patients remain well. What more reward you can have as a general practitioner? He is completely free of his symptoms. Depression is miserable. You treated him, you got him out of it. And even this 34%, they had another episode, you treated him. So 65% either remain recovered or may have a second episode, but again recover. That is why I say major depressive disorder, whatever the subtypes, mostly, depression is treatable, episode is curable, treatment is simple, escitalopram 20 milligrams, acetylene 50 to 100 milligrams. I am trying to oversimplify, my psychiatric colleagues may be angry with me. Most of the times it works, sir. But you need to hold the hand of the patient for the first 3 weeks. You need to see that the caregiver administers the medicines regularly. That is the mantra. At the end of 1.5 years, the reward of treating a depressed patient and making him recover from that it's absolutely satisfying. That is what with the last message, I said that thank you very much. Thank you very much, all of you, for your patient hearing. Thanks a lot. And over to Dr. Uma Shankar, who is the chairperson of this session. Thank you, sir. Thank you all.
Dr. Uma Shankar.
Sir, excellent presentation. Thank you very much, sir. I think everybody is enriched with their information, especially general practitioners. And even psychiatrists also, the junior colleagues, they may be definitely, they will be benefited with your talk, sir. I 100% agree with you that the patient caregiver is very important in the psychiatric practice. So usually I'll do that. Okay, I'll request, I'll plead the attender. Okay, Amma, this is my request from on behalf of me for so and so period regularly. While anyhow you are going to give the food, after food you have to give this tablet. This is the important. In that way, I will play the patient. That is very important. So to help the patient. Thank you very much, sir. Your excellent presentation. Now I will go for the panelist, Dr. Anurag Srivastava.
Thank you, Dr. Umashankar sir, President of the IMA, President of Society Telangana State Branch, Dr. Jagannath, Dr. George Reddy, President of IAPP, Telangana State Chapter. Grateful to all of you for giving me this opportunity to talk which in the beginning I feel that this is almost a non-medical topic, and why has kindness been a theme for the Mental Health Week this year? This is a very well thought out because there's surprising which we thought about before. But before we begin, I thought that I will ask all of you to take 1 minute and think in the last 1 week, in the last 1 month, can you think of an act of kindness that you have all done? I'll off and allow you to think. If any of you type down an act that you may have done in the last 1 month in the chat box, we can have a look later on. It will be an interesting thing. Okay, so before we go ahead, let us define what is kindness. So the dictionary definition is the quality of being friendly, generous, and considerate. But there are some people who have talked about certain other things which might be important. Kindness said that kindness is something which involves you are doing something, you take your time, make an effort, which will help somebody else. Some people have said that it might come at a cost.
Anurag sir,
You might be spending your money.
Anurag sir,
Yeah,
sorry to
Dr.
interrupt. Can you switch off your video? Your internet speed is slow, so switch off your video so that we'll be able to hear you.
Very well, I will do that.
Thank you, sir.
Okay, is that better?
Yes, now your voice is better.
Very well. So some people insist that it should come human, which comes as a cost in order for it to be considered kindness. That you must have spent some time, effort, or money. But you know, kindness may not be as common as it should be, as it could be. Today, I'm trying to shift away from what kindness does for other people. If we are kind to other people, we always think that we are doing them a favor. We are being nice to them. They are the ones who are being benefited, and they are the ones who will reap the benefits of this kindness. But today I want to devote this presentation entirely to what kindness does for the person who is being kind, what it does for us when we are being kind to other people. One of the strongest things which have, and Harvard has come up with a study on happiness, which is now more than 75, 80 years old. It has had 5 directors. They have followed people from birth for all their lives. And if you look at one important finding from that study, is that the thing which causes the most happiness are human relationships. And the one single factor which is most important in maintaining good relationships is kindness. So you see, kindness becomes one of the most important things which keep you happy. Forget what it is doing for other people. It's helping them. But devoting resources to others rather than having more and more for yourself brings about a contentment, a lasting well-being. And the importance of kindness for the person who is being kind is unimaginable. So there have been many people who have conducted many experiments. Emmons and McCullough, what they did was that they will check whether can we train people to be kind, and can we make people more aware that they are being kind. So what they did was that they said people that you must count the act of kindness that you have done for 1 week. Just count the acts of kindness that you have done. And simply by doing that, they found that people became happier. They became more grateful also, but they became happier. So the single most important finding here is the close association between kindness and happiness in everyday life. So kindness becomes an important human strength that influences your own well-being. Happy people are kinder in general, and kinder acts of kindness increases the subjective sense of happiness. Now, kindness has basically 3 components. Number 1 is that you have to be motivated to be kind to other people. Second, you must be able to recognize kindness that others are doing. And the third is that you must enact kind behavior in your daily life. So motivation to be kind, recognition of kindness in other people, and then being able to enact that kindness. All 3 are important in being able to increase the subjective happiness. So if you're just thinking about being kind, but you don't do anything about it, then it doesn't help very much. Gratitude. Gratitude is recognition of kindness of other people. When somebody else is being kind, gratitude is of tremendous importance in subjective happiness. So you see, kindness works both ways. If you recognize that other people are being kind to you, or you count that you understand that you are being kind and you act on that, that is something which is of great importance in increasing the subjective happiness. So many benefits reported of people who have been kind. The simple one straightforward thing which comes up is mood improves. And we know that improved has a lot of benefits on the immune system. In fact, nowadays depression is seen as a disorder of the immune system, as a problem of an inflammatory response which is working against us. And these things are commonly linked, that the improved mood and the kindness which people are doing for other people helps prevents disease in the people who are being kind. Now there can be 2 kinds of kindness. One is strategic, so that I'm to other people because I hope that one will be kind back to me. You know, this group funding which happens, crowdfunding for people who are suffering from terminal diseases. A lot of people feel that, okay, I should contribute to this, help them, because Lord only knows, maybe one day I will need something and I hope that people will help me back. Strategic kindness. Then there is an altruistic kindness in which people are being kind without any gain for themselves. Now, what has been found is that the reward areas of the brain are active during strategic kindness. Altruistic kindness also fires those things up, but there is a special effect with altruistic kindness which is not seen so much in strategic kindness, and they have described this as a warm glow. Warm glow is because the anterior cingulate cortex, the subgenual part of the anterior cingulate cortex, lights up during altruistic kindness, and that is described as that feeling of contentment and warmth, which is very high when you are doing an act of kindness, without any gain to yourself. So your cortex is responsive to an act of kindness and it responds differentially. This is something functional MRI has helped us a lot to understand how this works. And you remember we said that one of the important things, most important things in people being happy are relationships. And in relationships, it has been found that people who are kind to each other, that is the single most important thing in a successful relationship. Small thing which I found interesting, so I thought I will put over. This is the lost letter experiment. So psychiatrists are familiar. We use letter experiment in testing for test judgment during our mental status examination. Very simply, an envelope which is addressed and it has something inside it is left accidentally on purpose on the street or at somebody, and people pass by it and their reaction is observed. What it entails, person who picks up the letter find it unstamped. So an effort is required. So he will have to go to a post office, get it stamped, put in some money, get it stamped and post it. Now, this was a study from Western Australia, and they found that people living in rich neighborhoods tended to post the letter much more than people who were living in poor neighborhoods. That means that it's easier to be kind when your basic needs are satisfied, when you are not worried about food and water, and when your Maslow's hierarchy, you are a little higher up, you're likely to be kind. The other thing of concern, which I'm not going to go here, is that in our public policy, Indian public policy, there is almost no consideration given to any kindness in these things, but I'm not going to go into that because I wanted to talk about something very interesting today about what is the basis of kindness. So there was this Italian neurophysiologist, his name was Giacomo Rizzolatti, in the University of Parma. He was mapping the cortex of monkeys, a particular kind of monkeys called macaques, macaque monkeys. What he noticed that when the monkey was reaching out for a peanut, a certain area in the brain started to fire. Those neurons were responsible for the monkey reaching out to pick up the peanut. But when the monkey was doing another task with the same hand, for example, scratching itself, those neurons did not fire. They felt that, okay, there are certain neurons, a group of neurons, which are firing for certain tasks only and not for others. Even though the same muscle group may be involved, but for one task, a different group of neurons is firing. Also notice something else, that there seemed to be two sets of neurons. One set of neurons was firing and the other was silent. It was almost like the other neuron was observing, learning. It seemed to be like a mirror to those neurons, and why they call it the mirror neurons. During this experiment, what happened was that sometimes the researchers, the human researchers, would reach out to the peanut to hand it over to the monkey. When they reached out to pick up the peanut, the mirror neurons, the monkey's brain fired. You see, the monkey has just seen the human pick up the peanut. Basically, the same neurons are firing, which fire when the monkey himself picks up the peanut. It became even more curious. It became even more interesting. It seemed that the monkey could make out what is the intent of the person. If the researcher reached out to an empty table where there was no peanut and pretended to pick up something, the monkey's brain was not firing. But when there was a real peanut, brain will. They went further. They inserted a screen. Now the monkey cannot see the peanut. He thinks that the peanut is there. And when the person reaches out behind the screen to pick up the peanut, approximately at the same time that the hand would pick up the peanut, the monkey's brain would fire. That means that the important thing which is happening here is when you see somebody else going through an experience, when you see somebody else experience something or doing something, your brain fires in the same way as if you are experiencing that thing. We all watch BBC. When the person is struggling with that, thinking, "Arey bhai, if you don't know, let it go. Don't take a guess. You will lose the money. Don't answer." Or if he takes a guess and he answers the question correctly, we are so relieved. We are so happy. There is a spontaneous outburst of clapping. Why are you feeling that? You are not winning any money. It is that person who is winning a crore. But what is happening is that when that one wins the prize, the neurons in your brain fire exactly as if you have won that prize. So you see, these mirror neurons are mirroring people's emotions in your brain. And that is the basis of empathy. To be able to understand another person's emotion, to be able to understand how the other person feels and what they are going through. And empathy is the most important ingredient in kindness. Now, what is the importance of that? In the last slide, I will just mention that. But here, one of the important things is that we are social people. If we are too isolated, it is not good for us. But if we are too enmeshed, that is also not good for us. An optimal balance in this integration is very important, and kindness is the glue which allows people to connect and maintain that. I will move over to the last part of it, that what is the role, what is the importance of this kindness? You see, when an infant is born, it is entirely absorbed in itself. It doesn't care about other people. I am hungry, I want my nappy needs to be changed. I don't care if it is 2 in the morning. I don't care if you are tired or not. I don't understand all of those things. I just want my comfort. That means that the child, little children are completely narcissistic, self-absorbed, in love with themselves. Now, over a period of time, what happens is that the infant learns to love other people. It gives up some of its self-love and starts to love other people. It starts to understand that other people have emotions, and it feels their emotions with the help of his mirror neurons. And then he starts to understand other people's feelings, and then he wants to help them. He wants to love them. He wants to take care of them. He wants to help them. And the more the child understands this, the more he will go away from self-love to loving other people. The movement from self-love to loving other people is what we call growth or maturity. If a person is not able to travel this path, they will be very self-absorbed. Their lives will be pretty limited, because people who only love themselves, very difficult to find contentment. So you see how much you have matured. You can yourself measure by examining truthfully who you are, because kindness is a sure indicator that you have moved, you have matured from loving yourself to loving other people. And it's a measure of how well your mirror neurons are functioning, how well you are able to integrate all aspects of this system in your life. And the more you integrate, the more mature you are. The more mature you are, the happier you will be. So thank you very much for your kind attention. Remember, being kind helps you much more than it helps the person that you are being kind to. And kindness and being kind can be one of the things which marks the maturity of your mirror neurons. It marks the maturity of your coping mechanisms, and it is a marker of how well you yourself will respond to the stressors of. Thank you very much, Dr. Umashankar sir. I thank you again.
Sir, very excellent presentation.
Over to you, sir.
Thank you very much, sir. Excellent presentation. I think everybody's know that what is kindness. I think I request next panelist, Dr. Harichandra Reddy, please proceed your presentation, sir. Please unmute your this thing, sir. Harichandra Reddy.
Good evening, sir. Firstly, thanks for the opportunity, Chairman, sir, and all the office bearers of IPS, IAPP, and IMA. It's a privilege to share a virtual stage with such distinguished individuals. It's a big ask to add pointers to what MS sir has presented, and it's naive on my part to say anything else. But like we all know, depression indeed is amongst the most common mental illness that we see every day amongst our patients. And I think the best takeaway from what sir has presented was how the GPs and other specialties also need to identify depression early and start treatment so as we save time before they run around hospitals and finally reach a psychiatrist at a much later stage. And coming to the theme that we have today of this year of the Mental Health Week, kindness, as Dr. Srivastava sir has already elaborately put it, it goes a long way, not just towards the patients, but as a society, I think we all are, society is defined by our attitude towards the mentally disabled or any disabled person. And it need not necessarily be, it should not be a sympathetic, it's not about sympathy, but it's more about compassion and understanding that it could happen to anybody. It could happen to us, it could happen to our loved ones. So it's not about how we sympathize with them. It's more about adding to, their happiness. And I think more importantly, I always stress on how caregivers do play a role in, helping the patient's outcomes. But also, I think kindness towards the caregiver is equally important because we must always have them and keep them in good humor also. Because most of psychiatric illnesses run long and they're chronic in nature, and caregivers also require that much assurance from us and that much, some kind words. So kindness indeed is a very important aspect. And I believe it must start at a very early age because kids, as they keep growing, I think that's where it must start because we are aware how certain European countries, some so-called developed countries have their civic sense, a little slightly different from sadly what we consider our own civic sense isn't on par. And I think teaching kindness starts from how we deal with, the kids at home and how they develop compassion towards another individual. So here we're not just talking about kindness towards the psychiatric patients, but towards people in general. So I believe it's a great theme that has been chosen this year for the mental health awareness. And I once again, thanks for this opportunity. And over to you, sir. Umashankar sir. Thank you.
Thank you, Harish. I think your presentation is good. And I request the Jagannath sir, Arminas, please.
Umashankar, any questions?
Okay,
Anyone
just
has?
okay. After that, I'll go for the questions.
Yes.
Okay. Now, in the chat box, I'll go for the questions.
Sir,
Yes.
Okay.
So you can find a question there at. Can I read it out? Is that okay for you?
Yes, please. Please go ahead.
I think probably MS sir will take this. This comes from Akshit Dandotkar. He says, "Good evening, sir. His doubt as a first-year junior resident of general medicine, he wants to know the red flag signs that he should be aware for early intervention in a patient who is possibly suffering from depression. And since there's a relationship with diabetes and hypertension, what are the clinching signs that he needs to look for?"
Yeah, I think that will be the the most important point, especially from the non-psychiatrist point of view. One is most commonly, as I told, that 70% of the times they present with some non-specific, unexplained, which any of your clinical evaluation and also the laboratory investigations do not explain, which a lot of times we are putting it as chronic fatigue syndromes and fibromyalgia. In addition to that, this kind of non-specific symptoms and insomnia. Insomnia is one of the very, very important marks. And especially, as I told, that we don't have to be in such a hurry also, but 2 weeks consistently. That's why I told the point, most of the time in the day, most of the days in a week, if the person is having these symptoms, then that will be the red flag. Along with the diabetes, hypertension, suppose you find that in spite of your better efforts, the patient is having certain symptoms which you cannot explain otherwise medically. In spite of this very well-controlled diabetes, suddenly the blood sugars are going up. Well-controlled hypertension, suddenly they are not like, the blood pressure levels are fluctuating. That can be the red flag. And sir, very clearly, say you're like in the first year, you said that I am not asking you people to refer every depressed patient to psychiatrist. My psychiatrist colleagues may be angry with me, but that definitely not. It is impossible for us to manage that. Start treating at your level. That is why today's presentation, I talked only about sertraline, escitalopram. I once again reiterate, forget about serotonergic syndromes and all those things. With those things, it almost never seen. If at all there is a problem, GI symptoms definitely. Sexual side effects, I do agree. 25-30% of them have sexual side effects which are disturbing, but this is dose related, second is time duration related. Once you remove the antidepressant, they'll become all right. Start giving antidepressants, start giving escitalopram, which can be given from the age of 10 to 90. Drug interactions are very, very minimal. Start at 5 milligrams to give up to 10, 15 milligrams, 20 milligrams. Patient, quite a lot of them respond. So don't send the patient to us unless you find them psychotic or intensely suicidal, or it's a bipolar depression, or like a chronic depressions. Manage it. First, you can treat it well. If not possible, at the end of 6 weeks, if you are not showing response, then refer to us. That's what I say.
Thank you, sir.
I think only one question is there.
Yes.
Only one question is there. I request our senior colleagues kindly give their message. And Dr. Ashok Reddy is here. Sir, please give your message.
That's really very
good evening. Good evening.
Ashok Reddy put the kindness kiosk to encourage kindness. That's really great, Ashok Reddy. Congratulations.
Good evening, everyone. It was a wonderful session from both MS Reddy and even Dr. Anurag has really clarified about the kindness, even neurobiology of it wonderfully. And Harish, congratulations all of you. And the message what Dr. MS Reddy has given, it has to be appreciated. The depression is the commonest condition which can be treated. Most of the cases can be treated by general practitioners. Otherwise, it's going undiagnosed, undertreated. People are just suffering because they're not getting treated. More than 50% of the depressed patients can be managed by the GPs and non-psychiatric physicians at their level and refer only when it's complicated cases, resistant cases, or psychotic, which needs admission, or the suicidal risk. The wonderful message was given. I'm just repeating the same thing because it's a very useful message. Thank you, sir.
Thank you, sir. Now I request Ajay Kumar Saxena, sir. I request Dr. Ajay Kumar Saxena, sir, please give your message, sir.
Ajay sir, unmute yourself. Ajay sir,
Please
please unmute
unmute, sir.
yourself.
Yes, sir. Not audible, sir.
Sir, we can have later from sir, others.
Shall I go to Dr. Mayurnath Reddy? Sir,
Yeah.
Dr. Jay Mayurnath Reddy, please give your message, sir.
Thank you, sir. So today we have very good session from Dr. M.S. Reddy and Dr. Anurag Srivastava and from Dr. Harish Chandra Reddy. So I went throughout this week. All the deliberations are very good. All the speakers done very good job. So I congratulate Dr. Jagannath, Dr. George Reddy, and Dr. Minhaj taken very good initiative. I think this is the first time I think very week-long good session went on very well taken up by all the people. Thank you. All the best.
Thank you, sir. Sir. Now I request Dr. Kishan, South Zone President, please give your message, sir.
Oh, thank you, Dr. Umashankar. Before giving message, I am able to recognize Dr. Jagannath, IPS, TSB President, Dr. George, IAPP President, Dr. Harish, Dr. MS Reddy, Dr. Yadav, IMA leader, and Dr. Anurag, very good lecture. Then Dr. Mayurnath, Dr. Ajay Kumar Saxena, Dr. Raghuram Reddy, my teacher. Thank you very much. And I do not take much time, only a few words from my side. There is in Indian philosophy, the kindness, mostly the Buddhism, in Vipassana, they start seeing with kindness on self, kindness of others. There is a way of practice with Vipassana. That is, again, in Indian Sanskrit, it goes to Karuna Rasa. So there are, everybody knows different rasas. In that, Karuna Rasa is one of the important rasa to cultivate by a human being in evolution of for better human being. Then, unless you have ahimsa nature, killing others, killing any being, that is ahimsa paramadharma, you cannot cultivate this type of higher values, and especially emotional values. So everybody knows that empathy is very important, and which includes all these things, but is something different. And every psychiatrist should practice. I think the Telangana State Branch as well as IAPP is doing wonderful job. I'm expressing my thanks to both IAPP and IPS Telangana State Branch, especially Dr. Minhaj. And the credit goes to, we started the journey of new branches of Telangana State Branch after formation. Raghuram Reddy is the founder president of IPS Telangana State Branch, and Dr. Sridhar Raju, founder president of IAPP. We also having separate organization from Telangana state level, that Nursing Home Association, Private Psychiatric Nursing Home Association. I think the togetherness journey started with the Jajid and Minhaj, and Dr. Prasad, our request is pending since 2-3 years. He always used to tell us, so let us go together, so naturally the activities will be strengthened. So I think Minhaj and George started the journey. Wish you all the best, and thanks to both of you people and Jagannath, and has given an opportunity. Thanks to Minhaj, George and Jagannath for giving opportunity to Karimnagar Psychiatric Society to start the program for an inaugural session of this week-long programs. Thank you very much for that opportunity. I think we will continue the legacy of togetherness, include even you can include now you already include IMA. That is a wonderful thing you are doing. I think Minhaj credit goes to Minhaj and Dr. Yadav and Dr. Vijender Reddy. And now you can include in future that private psychiatric nursing home associations also. So like this, I think let us go together. Now we started the legacy of Telangana in different organization. Now you have togetherness should go ahead. I think, thank you very much. And thanks to all teachers and who are here. And thanks to Yadav Bhaiya. It's very nice to see you in IPS forum. Thank you. And over to organizers.
Thank you, Dr. Kishan. Now I request Dr. Vishal give his message. Dr. Vishal.
Hello, good evening, sir. Sir, it's a nice lecture, sir, and excellent presentation. And I would like to thank and congratulate the organizers, IPS TSB President Dr. Jagannath sir, and IAPP President Dr. George Reddy sir, and IPS TSB Secretary Dr. Minas sir, and today's chairperson Dr. Umashankar sir, and panelist Anurag Srivastava sir, and Harish Chandra Reddy. And I would like to thank and congratulate all the IPS TSP members for wonderful
Hello.
chairperson.
Hello.
Hello, Vishal.
Any problem?
Hello, sir.
Any problem?
Yeah.
Sir.
You completed?
Sir. Hello.
Yeah. Go ahead.
Go ahead.
Sir, over to organizer, sir.
Okay, thank you. Thank you, Vishal. Your excellent message. Now I request Dr. Sai Krishna. Dr. Sai Krishna.
Dr. Sai Krishna, Treasurer, IPS TSB. Sorry, editor. I'm very sorry. Dr. Sai, are you there?
Okay.
Good evening, all.
Yes.
Good evening, all.
Yes, Sai. Yes.
First of all, I thank President Jagannath sir and all office bearers and all the speakers and IMA for giving us an opportunity to enlighten regarding mental health. Hope such kind of programs continue every year so that general practitioners will become more aware regarding mental health issues so that we can serve society in a better way. Thank you.
Thank you, Krishna, Sai Krishna. I request Dr. Vasista. Dr. Vasista.
Sir, good evening, sir.
Good evening.
Thank you, everyone, for the warm welcome. And I thank Dr. MS Reddy, sir, for a very beautiful presentation. It was very lucid. I actually am happy to hear from you all, sir. You are all my teachers. And thanks for the beautiful coordination between IAPP and IPS TSB. And thanks for enlightening us, sir. Thank you. Thank you very much.
Thank you, Vasista. I request once again Dr. Ajay Kumar Saxena, sir. Once again, I request Dr. Ajay Kumar Saxena, sir.
Sir, good evening, everybody, to my teachers, my seniors, my dear friends. I'm sorry I could not unmute myself all this time.
No problem.
I was trying my best to do it. So I felt this year's program, Mental Health Week, has been the best that I have ever seen. We have had such marvelous speakers. So much of information has been disseminated. And it is so good that this time we have involved IMA, our respected members in IMA, our colleagues, because as everybody rightly said, our patients first go to them and then come to us. And talking about depression, Dr. MS Reddy, I shouldn't be saying he has done a wonderful job because I'm too small to say that. He is always doing a great job, whatever he does. His lecture has been fantastic. Anurag has been so clear about what kindness means. And we are lucky as psychiatrists. I always felt that we are very lucky to be psychiatrists because that is one quality of empathy and kindness is what we are taught. And for that, I'm also grateful to my teacher, Dr. Raghuram Reddy Garu. Thank you all for calling me for my comments. Thank you, sir.
Thank you, sir. I think everybody is over on the screen. If anybody is
Dr.
still...
Umashankar,
Yes, sir.
I want to
Yes.
just make one additional
Yes, sir.
suggestion.
Please, sir. Go ahead, sir.
We are really this year we have done a wonderful job all coming together, including the IMA during the Mental Health Week. I think next year all the organizing, the leaders should take up the lead to include even non-medical organizations, like even Jagruti is there.
Yes.
Like Jagdish Babu is working for Jagruti. We can reach others, common man, also through this platform in the next year Mental Health Week. I think this is a suggestion from my side. When non-medical common man's group should be included so that we can spread our awareness about mental health. Thank you.
Yes, sir. That's a good initiation, sir. I think that is the persons, they have to know what is the mental illness, how they can help the people. That is a good message, sir. Definitely, I think I'll pass on to our seniors as well as the organizers, sir. Thank you very much, sir. Here, I want to say that one thing on is a depressive illness. I think all the medical practitioners, those who are, suppose if most of the times they are spending a lot of time with the patients, but if they could not understand what is diagnosis, how to go for that type of patients, if they spend little time, I think most of the times they are vague symptoms, vague complaints, like somatic symptoms, somatic complaints. They cannot treat them. So they will frequently coming back for various. In that case, if they spend little time, definitely they can help them by their kindness and they can do better job. Suppose if they could not do justice, then only they can refer to the psychiatrist. Need not refer initially itself. They can spend little time, they can do good job. So with this, I think it is a very important day for all the psychiatrists and other people for creating the awareness among the public and as well as the colleagues. Thank you very much, the organizers, giving this opportunity to share this important day evening session. Thank you very much giving this opportunity. Over to Dr. Jagannath.
Thank you, Umashankar. I think whatever Dr. Ashok Reddy has suggested, we want to conduct programs on various occasions, like for the Children's Day. Probably we can have one more session on the common mental illness among children for the benefit of teachers with whom the children spend most of their time, and to the parents. So we would like to contact the association of the teachers and the parents association. Probably we can have a separate session for them. Likewise, probably we would like to for the No Tobacco Day, we can conduct a program like that. For special groups, we would like to conduct. This is only an initiation we have taken this time. We do not know how we are going to organize it. And with the help of our General Secretary, Dr. Minhaj, I think in the week-long sessions, we have done very well. And I think we are looking forward for more and more sessions like this. Doctor, I forgot to thank Dr. Anurag Srivastava and Dr. Harish Reddy earlier. Thank you, Anurag, for accepting our request, and thank you, Harish, also. Dr. Minhas, Dr. Minhas, unmute
Thank you, Dr.
yourself.
Jagannath, sir.
Yes.
Thank you, sir.
Okay. Minhas, yeah, you can talk. You can say a few words.
Sir, I'll give vote of thanks if everybody is fine.
Any further questions? Dr. Yadav साहब, आप कुछ बात करना चाहते हैं?
So carry on. The program has done the program was excellent program, and the association with your association is also a good part. We should look forward in the future also that will maybe because of this COVID pandemic, everybody is coming together. Otherwise, in the physical form, I don't think it would have been this possible, because at the comfort of home, you are talking to everybody because of all these Zoom meetings. Earlier, we never had this all Zoom meetings. Because of the COVID, only everybody has entered into this COVID. these Zoom meetings like this. So
Okay.
we have regular academic activities almost every week or once, like 3 times in a month, one oration with 2 CMEs. We are regularly conducting all these programs. Sometimes we get a speaker from psychiatry department, sometimes from cancer department, sometimes from general practitioners, all the faculties. So we have 11 orations in a year. So one oration in a month and 2 to 3 CMEs also. So that comes to one program every week, or at least 3 programs in a month. So we are doing wonderful academic activities. Minhas knows, I think Minhas can inform you all about our programs. Whenever you feel like coming to IIM Hyderabad City, you are all welcome.
We are all your members, sir. IMA members.
Thank you, sir. Thank you, sir.
Thank
Sir,
you.
I would request Dr. George Reddy to speak about something. He was busy in calling all panelists. Dr. George Reddy, please, your comments.
Yeah, thank you, Minas bhai.
Sorry, George, I missed
About
you
mental health
for your
awareness.
comments. Please go ahead to your comments.
I think this is one of the best program I ever felt, because it was meeting all in this pandemic also. I think thanks to Corona anyway. And I think the future is all going to be webinars, I feel. The physical conferences, I think, will be a bit, they are going to be speeding less, but these webinars are going to be a super duper hits in the future. And as we have seen this World Mental Health Week, I think we should definitely thank IMA, though we are all, I am IMA of Airport Branch, but we feel that happiness that we are with the IMA members, and though daily we meet our IMA members, but this kind of platform, IMA members coming and encouraging, I think, because many times we feel we psychiatrists are neglected. Thanks to IMA, because it is really encouraging, and hope we see that we conduct more and more programs, at least virtually. And today's talk, depression, it's really, I think we all should say that almost all these general practitioners know about depression. Many of them use antidepressants, and otherwise, I think our hopes all would have been full, because they are helping at the front line. And only I think that kind of difficult and tough times, I think we are there for help. And I think this should be continued, because the general practitioners patients are more comfortable with them. And today's World Mental Health Day closing, I should really thank Dr. Jagannath sir, Dr. Minhas. I think it's wonderful today. We could see almost 100 members attending today's program. Last but not the least, I would really thank all my junior psychiatrist friends, colleagues who were just like one button. I messaged them. I think many were there. And definitely thank you all, boys and girls. Hope we will continue this legacy, and we will be active by participating and make these programs a big cheers. Thank you, Dr. Minhas.
Thank you, Dr. George. Now I think it's almost 10 to 10. Minhas?
There are somebody who wants to talk, sir, from this group.
Anybody?
Somebody has raised their hand, sir.
And I'm Dr. Ashok Reddy. I just want to make small comment. Suggestion to Dr. Jagannath, Dr. George, and Dr. Minhas. Think of Police Officer Association and Bar Council for the future. Thank you.
Yes.
Sir, Dr. Mustafa Khan Muhammad.
Hyderabad City branch member.
Minas bhai?
I am trying to promote him.
Yeah.
Dr. Mustafa Khan is Joint Secretary, IMA City Branch.
Yeah, Dr. Sahab, over to you.
Dr. Mustafa sir, do you want to say something? Give some message?
Sir, it is not, his name is not showing his microphone, sir. Maybe it's not working on his phone.
Okay. Microphone is not working.
You just can't take him on.
Okay.
Anyone would like to say something? Anything, please? Okay. Dr. Minhas?
I think we should encourage the youngsters to talk, sir.
Youngsters, yes.
There are so many youngsters, sir.
Probably you can give us some ideas which we can follow in the days to come. Any youngsters, any young psychiatrists?
I'm promoting Arman. Dr. Arman, please unmute yourself. Arman is first year psychiatry resident in Deccan Medical College. He is also daughter of one of our psychiatrists from Warangal. Dr. Arman, please unmute yourself. I think she's shy. Raghuveer. Dr. Raghuveer, welcome.
Sir, good evening, sir.
Rajbhai, anyone? Dr. Raghuveer, please give your message.
Sir, good evening, sir. I think this was been a very wonderful opportunity for us to actually interact and learn a lot from our senior colleagues and psychiatrists, sir. I think this has been a wonderful event. I think the first time we actually did it online, and I'm very, very happy to be a part of this, sir. Thank you.
Thank you, Raghuveer. Anyone else, please?
Dr. Dinesh, Vice President, Hyderabad Psychiatric Society. Dr. Dinesh, sir.
Minhas, Dr. Preeti Swarup is here. Is he here?
No, sir. Dr. Preeti is not there, sir.
Yeah, Dr. Preeti is not there.
We have conducted this year's awareness program both by IAPP and IPS, along with Karimnagar Psychiatry Society, Hyderabad Psychiatry Society, IMA State Branch, and IMA City Branch. I think we all came together, and then we have conducted this program. Okay, Minhas.
Yes, sir.
Thank you very much, all viewers. Now I request you to propose vote of thanks.
Thank you, sir. On behalf of Indian Psychiatric Society, Telangana State Branch, Indian Association of Private Psychiatry, Indian Medical Association, Telangana State, Indian Medical Association, Hyderabad City Branch, Hyderabad Psychiatric Society, Karimnagar Psychiatric Society, I thank all the attendees, all the panelists, all the speakers, or the chairpersons for their wonderful contribution throughout the week. You all didn't get tired. You all came dot at 8, stayed with us till 9:30. Today you are staying with us till 10 o'clock. I thank you one and all. It would be too long if I take all the names, but some names I need to take. I need to thank Dr. Raghuram Reddy sir, Dr. Prasad Rao sir, Dr. MS Reddy sir, Dr. Chandrasekhar sir, Dr. Ashok Reddy sir, Dr. Uma Shankar sir, Dr. Kishan sir, our South Zone President, who have all taken out time, Dr. Ajay Kumar Saxena sir, who have all taken out time and came for these programs. I would also like to thank members, senior members from IMA, Dr. Sanjeev Singh Yadav sir, Dr. Vijendra Reddy sir, Dr. Rajendra Kumar Yadav sir, Dr. Krishna Pawan, who is also my colleague at Deccan Medical College, I would also like to other colleagues, Dr. Sai Krishna, Dr. Vishal, Dr. Raghuveer, Dr. Preeti Swarup, Dr. Dinesh, Dr. Nivedita, and all my colleagues for giving their valuable time. Last but not least, I would like to thank both my presidents, Dr. Jagannath sir and Dr. George Reddy sir, who have given me free hand to conduct this program, and they were all supportive. They supported me whenever I requested. They supported me. Dr. George, he had sent uh, personal messages to everyone so that they attend. Dr. Jagannath sir, he had lots of ideas, and he is so calm, and he puts on his ideas so nicely. I am thankful to them. I I am also thankful to today's presenter, sir. Uh, my thank would be incomplete if I don't thank Dr. Anurag sir and Dr. Harish Chandra, who's like my younger brother. Thank you, one and all. Thanks all the PGs for attending, all the IMA members for attending uh, this program. Thank you, one and all. I would also like to thank our technical support for the whole week, Anil Martin, who has also taken our request to extend today's program, and definitely our sponsors, Hanch Pharmaceutical. Thank you. If I have forgotten someone, please forgive me for my ignorance. Thank you.
Excellent vote of thanks, Minhas. Then I will conclude the session. Okay, good night. We close the
Good night,
session.
sir. Thank you.
Thank you, sir. Thank you.
Jai Hind.